can he ever become open? But
Yes, ma'am. We are live now.
Yeah. So good evening, everyone. Thank you so much for joining us for today's webinar on the Scope and Trocar series. This is a very important and timely webinar. I am Dr. Malaraj, the convener for this Scope and Trocar series. And this is the sixth episode of the series, which is being conducted by IAGE every month. So today's webinar, we'll diving into the topic of complex deep infiltrating endometriosis, wherein we'll explore into the complexities of bowel endometriosis, the diaphragmatic endometriosis, and also generally the deep infiltrating endometriosis. So today we have two renowned international speakers, Professor Horace Roman and Dr. Benjamin. So both of them are from the IFRM board of France and who brings a wealth of experience with them. So I had the privilege of visiting their place in Bordeaux and was amazed at the phenomenal work they were doing. And also I wanted each and every endoscopic surgeon to have an overview of this amazing work on endometriosis. So we have organized this webinar along with IAGE. So we are also thrilled to have our very own Dr. Abhishek Mangeshikar, who is also doing a very amazing job in our country on endometriosis. So to moderate this webinar, we have senior endoscopist Dr. Prashant Mangeshikar sir and Dr. Korean Joseph sir, and who would be interacting with these speakers and share the experiences as well. So we have the honor and privilege of welcoming them to this webinar. So we have also given adequate time for the speakers so that they don't feel rushed, so that all the topics are addressed in an adequate manner. We also have two young endoscopic surgeons along with us as our coordinators, Dr. Priya Gupta and Dr. Niveda. Dr. Priya Gupta from Rajasthan and Dr. Niveda is from Chennai. So now I would like to welcome the President of IAG, Dr. Kalyan Bamde, to deliver his welcome address, please.
Welcome everyone for this Scope and Trocar episode, which is number 6. And I'd like to congratulate Dr. Malaraj, who is doing a wonderful job as a coordinator as well as MCM member of IAG. I thank Dr. Priya Gupta, Dr. Niveda for being a MOC of this session. DIE is a complex process and disease which requires a lot of precision in the work, that is starting from the ultrasound, MRI, and then managing these cases actively. So we have specialists from international as well as national figures, Dr. Horace Rahman, Dr. Benjamin, and Dr. Abhishek Mangeshikar, to guide everyone about this issue. And I'd like to thank Dr. Prashant Mangeshikar, sir, Dr. Korean Joseph, sir, for being a chairperson for this valued session. Over to Dr. Malaraj for the further proceedings.
Yeah. So thank you so much, sir. Yeah, Sahiti, share. So we seek the blessing of the Almighty for the smooth conduct of this webinar. Yeah. Next slide, please. So I'd like to welcome our coordinators, Dr. Priya Gupta and Dr. Niveda. So Dr. Priya Gupta is from Rajasthan. She is an endoscopic surgeon and the national coordinator for FOPSI Family Welfare Committee and chairperson elect for FOPSI Family Welfare Committee, and also the West Zone coordinator for the same. And also she is also the president of the Kota Obstetrics and Gynec Society. So next we also have Dr. Niveda Arunachalam. Next slide, please. So Dr. Niveda Arunachalam is a consultant in Prashant Hospitals, Chennai, and she is also a budding endoscopic surgeon. And she is has special interest in high-risk obstetrics as well as reproductive medicine. So I would like to invite our coordinators to welcome the chairpersons and start the proceedings. There is a small change. Dr. Benjamin has not joined yet, and so we will request Dr. Abhishek Mangeshikar to start with his talk.
Sure, ma'am, can I introduce you, ma'am?
Yeah, carry on.
So yes, ma'am, it is my privilege to introduce Dr. Malaraj, madam, whose guidance and vision has been the driving force for this event. So let me take a moment to formally introduce her professional journey. Madam is the Vice President of IAG Tamil Nadu Chapter, Founder Secretary of IAG Tamil Nadu Chapter. She's a Managing Council member of IAG. She was a Treasurer in Oxy 2024. Madam is a Joint Secretary of CMS in 2023 to 2025. She was a past Secretary of IMS Chennai Chapter of 2010 to 2012. And she is trained in advanced endoscopic surgery in Strasbourg and China Medical University. So Foxy and ICOG recognized training center for endoscopy, trained in aesthetic gynecology under Dr. Red Allenson, California, accredited menopause practitioner. She won the Best Doctor Award for Tamil Nadu MGR University, Best Video Award in IAG 2018 Lucknow. She's an operating faculty in various faculties conferences. Dr. Sivrudra Sinha Award of AIC in 2006. Dr. Stella Paul Award for Excellence in Minimally Invasive Surgery in IOG 2012. And she's authored many chapters in various textbooks. She is a managing director of Firm Hospitals.
Thank you. Just go ahead. Yeah.
So, ma'am, shall we start with the very first session? So
we can start with Dr. Abhishek Mangeshkar.
Yeah, madam, surely. So good afternoon, all my respected seniors and all the dignitaries here. On behalf of IAG Scope and Trocar webinar series on complex deep infiltrative endometriosis, I would like to extend my warm welcome to the very first session, that is from imaging to scope, MRI guided surgical management of DIE. For this, I am really honored to introduce our chairperson for this session today, Dr. Kalyan Barmade, sir. He is the President IAG. Can we please have the sir CV slide, please? Dr. Kalyan Parmade sir is the Director of Latur Fertility Center, IVF, and he's currently the President IAG. He was the Chairperson Infertility Committee AMOX from 2023 to 25. He was the Chairperson of the Public Awareness Committee FOXY from 2019 to 22. He was the Executive Managing Council member of IAG from 2017 to 2025. Maharashtra ISAR chapter from 2018 to 2025. For AMOX from 2016 to 2024. He was the President of Latur Society from 2020 to 20. Thank you, sir. Thank you. And I will be really grateful if you can just further guide us with the event and make a formal introduction of a speaker, Dr. Abhishek Mangeshkar, sir.
Dr. Abhishek Mangeshkar is a budding surgeon, but mind you, he's not a national, he's an international faculty now. He's a laparoscopic and robotic gynecological surgeon, founder and director of Indian Center for Endometriosis, and consultant laparoscopic and robotic surgeon at Bridge Candy, Jaslok, and Saifi Hospital. He's a level 2 neuroperiologist, and he's a board member of ISON, ISG, and APACH. Welcome, Dr. Abhishek Mangeshkar, who is going to throw light on MRI-guided management of DIE.
Thank you, Dr. Barmade, for the kind introduction, and to Dr. Mala for the invitation to join this webinar. We just returned from a fantastic workshop in Bordeaux, and clearly there were a lot of insights gained there, and it's truly her selfless nature that she took it on the onus immediately to share it to the Indian audiences on a much wider platform. So thank you for that. And I'm going to share my screen. So my topic for today is going to be how we make the diagnosis for endometriosis. So this is very important because the days of, back when the big endometriosis surgeons said, we will put in a laparoscope and figure out what to do are gone. Now you have to see it before you do it in the OR. You have to see it and you have to talk your patient through the diagnosis, through the procedure, through what kind of procedure you're going to be performing on the bowel and so on and so forth. And hopefully, I have shortened it down for half an hour. It can be a very long lecture otherwise. But to be able to at least start to make the diagnosis yourself in the OPD, and hopefully we're all doing our own ultrasound, or at least if you're working with a sonologist, try and be around when they're doing the scan for these patients. I have no financial disclosures, and the objectives of my talk today are going to be what we need to know pre-op as endometriosis specialists, what we can do with ultrasound, what we can do with MRI. We look at the evidence and we look at some case studies to keep this a practical learning experience And I have some old case studies, so we can look at those and see how the decision making is arrived at. So, of course, we know that in most countries, TVS is the first line of diagnosis, but not all ultrasounds and not all MRIs are equal. It is very operator dependent on and who is using the machine or who is reading the MRI. That is more important. So we're going to discuss diagnostic accuracy of each modality, and we're going to see how this helps us in our preoperative planning and in which particular situations may require higher imaging like an MRI or so on and so forth. Okay. And 1 second, we're having a bit of a screen share.
So Dr. Abhishek, Dr. Benjamin has joined. Should we?
Oh yeah, you
should-
can take over if you want.
No, it's okay.
Uh,
So, hello, my friend.
oh,
How
hello.
are you?
Hello.
Welcome
Sorry.
to you, sir. Yeah.
No,
So,
no,
I
you
know
can
you have a meeting, Benjamin. If you want to finish.
finish. You start. So finish your lecture. I will be after you. No problem.
Okay, I will be
Okay.
very quick.
thank you so much.
Happy to see you.
Okay, so we know that our imaging, what we see on the ultrasound, has to match up with what we see on the MRI, and also what we will see at surgery. So if you see here on the left, you see the ultrasound has 2 nodules in the bowel, and then the same thing when we do a resection, we have to confirm those 2 nodules, and similarly on the MRI. So just to speak briefly about colonoscopy for endometriosis and why it should never be done, is when you look at this study, they looked at 174 patients with bowel endometriosis, where you had only 2.6% where the infiltration was into the mucosa and 10% into the submucosa. So colonoscopy failed to diagnose the endometriosis in 92% of these patients, which leaves us a sensitivity of 7%, which is terrible. So it's you're better off flipping a coin than doing a colonoscopy for a patient of deep endometriosis. Hold on. Yeah. So, and we know from the types of bowel nodules, we can do a shaving, we can do a disc excision or a segmental resection, which should be restricted to nodules that are very large in size, more than 4 or 5 centimeters. If it's more than a third circumferential involvement, or if there are multiple nodules in close proximity. When we speak about ultrasound, we have the transvaginal ultrasound, or you also can do a sonovaginography where they put a gel or a saline in the POD. And you can do tenderness guided. And I don't know if there's a role of 3D ultrasound for endometriosis. It is more for Mullerian anomalies and so on and so forth. Now, this is the protocol. So a standard ultrasound just looks at the uterus and the ovaries. But for endometriosis, we have to not just look at the uterus, we have to look for features of adenomyosis. So look at the endometrial stripe, look at anteverted uterus, or if there's a retro or mid flexion of the uterus. So that means your anteverted uterus is being pulled backwards by disease along the posterior compartment. If you have ovaries, look for the presence of endometriomas, look whether they're fixed or stuck to the uterus or below the uterus or they prolapse in the pouch Douglas. Those are surefire signs that there is endometriosis on the uterosacral or probably down below in the parametrium. In the anterior compartment, so you look at the UV fold, you look at sliding of the UV fold, you look for thickening of the bladder wall to see if there is any bladder endometriosis, and then you move your probe to the side and look at the ureter jets to rule out any hydroureter, and you follow that down into the parametrium and look at bladder sliding. So for the posterior compartment, we look at high and low sliding, and then draw an angle between the bladder insertion to the back of the cervix. So that's the uterine torus, and then we check for sliding there. And when you turn axially there, you will be able to evaluate the uterosacrals. I'll show these to you in videos. So, and of course, don't forget to scan the kidneys. You shouldn't miss a hydronephrosis secondary to parametrial disease. So now this is what a normal sliding looks like. So if you see the uterus in a sagittal plane, it's being pushed, and you see the rectum below is moving freely. And this, you usually have a little more difficult in a retroverted uterus. So you see here where we're having some fluid in the pouch of Douglas that helps, and you see good clean sliding there. Here, you have absence of sliding. So when you push against the uterus, the posterior compartment is moving along with the uterus. And here, when you have some rectal adhesions, which is described as the Indian headdress sign or the quill sign, and you see there's a small nodule there, but you also have fat stranding of the bowel completely towards the posterior wall of the uterus. And here, this is the first sign. If you see an ovary stuck directly below the uterus, like this in the sagittal section and this in the axial section, means the ovary is adherent as well. And here, similarly, you can see this right ovary and you see this bowel that is kind of stuck there. So your bowel is stuck to the ovary, that's an absent. And you have a small nodule in the bowel to where it's stuck towards the right ovary. And then, of course, you have the classic kissing ovary sign. That means both your ovaries are pinned behind the uterus and you have endometriomas there. But always when you have kissing ovaries, you don't get distracted by the chandelier on the roof, so you're missing the hole in the floor. So you always have some deep disease. The rectum is very likely going to be adherent or there's going to be a nodule in there. Now for adenomyosis, you'll obviously see an enlarged uterus and you get this dense structure, which is going to throw Venetian blinds off. I have a better video of that. So here, when we sweep, I don't know why it didn't move, but when you sweep the adenomyosis, you get these little shadows coming off, and that's diagnostic. There's a very interesting paper on the Musa criteria for diagnosing adenomyosis, and that's what we will use. So now we're just going to look at a quick video on the different kinds of adenomyosis. So this is a small lesion of adenomyosis that's infiltrating into the round ligament. So we excise those as well, and you can see these quite well on imaging. They will show up on MRI. And as well as if you know how to image the round ligament on ultrasound, you should be able to see this as well if you look close enough. So that's excised very quickly from the left and the right side, the round ligament, and then we'll go posteriorly to take care of the posterior compartment disease, and then do a robotic adenomyomectomy. I don't recommend doing these surgeries laparoscopically anymore, at least in my practice. I said with the robot, we have much better outcomes in terms of being able to excise the disease, lower recurrence rates, and also I think the overall pregnancy outcomes will be better. We still haven't checked the data on that as yet because it's very limited, but at least from what my personal experience is that it is much more comprehensive in the excision of the adenomyosis. Therefore, we also use ICG in the cavity to make sure we're not entering the cavity and also to help us in the reconstruction in the most anatomical fashion. So that's the ICG in there. ICG also stains blood, so don't think that just because you're seeing it, you have to be able to understand where the limits of the cavity are. So we've not breached the cavity, but we're close to it. So and that's the complete excision of the adenomyoma. And then we take a big stay suture there, and then I run the rest with V-lock. I'm going to go through this very quickly because this is, I think we're more interested in the imaging here. And of course, for the bladder, you go put your probe between the uterus and the bladder and do a sweep across, and then you can see the nodule in the muscularis as well, and then plan the excision. The MRI is very useful for this as well, and you can see this nodule here. This is a primary bladder nodule, which means it's not secondary to a cesarean section. It is similar to how you have type 1 bowel nodules, which are secondary to a posterior wall adenomyosis. These type 1 bladder nodules are secondary to an anterior wall adenomyosis. So here is that same patient where you see, you put in the scope and you have this big retraction of the bladder. You can see a small fibroid here, but there's definitely adenomyosis posteriorly. So for any bladder endometriosis, the steps are very standardized. I believe Horace, of course, has a paper on how this is done. So you develop your paravesical spaces, and then, so that's on the right side, and then you open just above the round ligament and then extend it to open the left paravesical space. Moving forward, then, of course, because you're going to have a big bladder nodule, it's worth possibly mobilizing from above towards the cave of Retzius. And here, a very important step is to identify the uterine artery, which you can see pulsating right there, what we're zooming on in, and opening the space of Shirishet above the uterine artery to then mobilize the bladder away from the uterus. So just like you would during a hysterectomy, of course, we're not doing a hysterectomy here. And now I'm going to open up the space superior to the bladder, so that going towards the cave of Retzius, to drop it down. So when I do excise the bladder nodule, Now we're doing a cystoscopy concomitantly, and we're going to use the light of the cystoscope to guide where we're going to make our incision. So my urologist is sitting just above the nodule with the light, and I'm going to use his light to help guide where I'm going to make my incision. So we're not going to excise any more bladder than we're supposed to, and that's the cystoscope. And we're going to then reflect the cystotomy. Now, what we haven't seen, obviously, is my urologist has already taken a resectoscope and marked the limits on the mucosal surface of the bladder for me. So he's going to help me mark that, and I'm just going to kind of connect the dots and excise the nodule. So it is a very large nodule, so we're trying to be as close as possible. If you can see, there's a double G stent in there, which is very close to the right ureteric orifice. The left one was a little further away, so I don't know if we stented that or not. So you see, we finish excising the nodule in totality, and the posterior compartment is going to be shaved off the top of the uterus where the bladder is stuck. And of course, that specimen will be retained on the side. And here we then suture the bladder in full thickness using a V-lock suture, and first run the posterior wall closed, inside out, outside in. And then once that's closed to some comfortable then we start superiorly and then join it to the inferior suture line until they overrun each other. And then, of course, we do our safety tests and are able to make sure that the bladder repair is watertight. So this patient will have an indwelling catheter for about a week, and then it was removed. Now, to look at bowel endometriosis, we have to understand what a normal rectum looks like. So here we have some fluid in the pouch of Douglas. That's cervix up there. This is the vagina. And this is the rectum. So you see this black line up here. That's the anterior muscularis, and then the posterior muscularis is down there. And this is the submucosa, and then this area is the rectum, rectal mucosa in between. And here, when you have a nodule in the rectum, you start following the anterior muscularis. You're not going to have a rectal nodule in the posterior muscularis. So you follow the muscularis and then measure the nodule from end to end. Of course, it is a curving nodule, so your measurement, if you measure it linearly, may not be very accurate. So you have to account for that. And here we have another example of a large nodule in the rectum. So we follow the muscularis, and you see down here, we have this nodule showing up. And similarly, as we zoom in, we will see that it's not just one, but there are two nodules in close proximity to each other. So what we know immediately there is that we will straight away require a resection. And then, of course, this is with an endometrioma, and you can see it's stuck to the right part. But below that, we have an infiltration into the parametrium down here. So we have a parametrial endometriosis, and then you always look at the ureters as well. Now we have here another example of a big rectal nodule where we follow the muscularis, and you can see this large infiltration into the rectum, which is stuck to the uterus. So if you see it behind the uterus, this is a type 1 bowel nodule. And then as you turn laterally, you can also see where it's stuck to the right ovary. It's the same one. And here's an example of a small rectal nodule. And this is a hysterectomized patient who still had symptoms. And if you see that this is the rectal nodule stuck to the vagina, so hysterectomy, leaving the disease behind in the rectum, requires another surgery. So we need to really change our approach with saying that TLH-BSO is the be-all and end-all of this. And here we have a type 2 rectal nodule in the upper rectum. So you see this is quite higher up. And then you have this, you can see the mucosa quite well inside, but you have this big nodule infiltrating into the muscularis. Now, to look at the ureters, you have to go lateral to the bladder and then look for the structure here. You have to move your probe around and look very closely. And if you see it, you can see the vermiculations of the ureter. And that's a very important step. And then you follow it down here to where it crosses the uterine artery, or rather the uterine artery crosses the ureter, and then look at if there's any swelling there or if you have any disease in that parametrium. So that's, but obviously MRI is much more useful. So speaking of parametrial disease, this is where we have the example. You have this big nodule, and this is the excision into the parametrium, like so. And then you can see This yellow arrow is the rectal nodule, and the red is the infiltration of the parametrium with a large hydroureter on the left side. So initially, on putting in the scope, you will see just the omas, I suppose. And if you're more observant, you would see that the rectum is stuck. And we have a manipulator lifting the uterus up. And as we mobilize the sigmoid colon and get access to the ureter, we see a very large hydroureter on the left side. Now this, as we start proceeding down this dissection, we're definitely going to see more of the hydroureter. And the fact that it's blue is already telling you that this ureter is a little devascularized because of the constriction that's occurring lower down. If you compare it to when we move to the right side of the dissection, right about now, you'll see this ureter is a lot nicer, white looking. So that's what we're going to focus on in this case. Moving on, we use ICG in the ureter. So you see there's a small infiltration in the right uterosacral as well, which I'm going to be very conservative towards because I know that I'm going to be very radical on the left side. So moving forward, coming to the left side, we see that the dye is not being taken up very well. And now we're getting into the Okabayashi space. Now, when we do this, we're going to be able to identify the hypogastric nerve. Now, of course, being nerve sparing in this case, where you have a large infiltration of the parametrium, is virtually impossible. And if you do robotic surgery, you see one of the tricks I use is I switch my cutting instrument, so my scissors, to my left hand when I'm working on the left side. This enables me to be a little more ergonomic. Then I suspend the ovaries. So I have access and then start mobilizing. Because we have a large bowel nodule, I'm going to prepare the bowel for a resection. And here we're going into the parametrium. So we lift up the ureter. The next step is to identify the hypogastric artery and vein, similar to another very interesting technique developed by the IFM Endo team. So you see, here's where the dye in the ICG was reaching up to. And that's where the ureter is getting strictured by this huge parametrial nodule infiltrating around it. And this is the most difficult kind of endometriosis when it's invading laterally in the parametrium. That's more difficult than a bowel nodule per se. And then once you do a parametrial nodule, you'll have to completely free up your ureter on all sides. So here we see, once we're able to get across, we can see where the uterine artery will cross momentarily. And that's where it's infiltrating into the cardinal ligament. And here we can start, we're going to initially start shaving this fibrosis of the ureter and then see what to do after that, whether this patient has been counseled for the reimplantation if required. The kidney function was good. It was more than 20%, so there was no indication for a nephrectomy. So we took a conservative approach. And as you see, once we start freeing up the fibrosis of the ureter, the dye is starting to ascend. So that means the ureter stricture is being relieved, which is going to give us more time to move or be more conservative towards the ureter. Now I'm pulling the nodule medially, and I'm going to shave the parametrial nodule away with the scissors. So this is being pulled towards the midline now, and we've mobilized the lateral aspect of the nodule. Now I know it's infiltrating into the vagina, so I'm going to make a calculated colpotomy into the vagina and perform a partial colpectomy. So once we see that you have the infiltration of the vagina there, that's the cervix up there. And then you can see how close the ureter is to the infiltration into the vagina. And we're going to finish excising this nodule across to finish removing the disease from the vagina, which then we will use the open vagina, in this case, for our stapling elements. So we prepare the bowel for the resection. And so just completely take the fat away. And once we have healthy pink bowel below the nodule, that's going to be the limit of our stapler. So we can use a robotic 60 short form stapler to disconnect the bowel. And then this is the nose technique. So I like to make an incision through the nodule. And then because I'm preparing for a side to end anastomosis, I don't want to lose any healthy bowel or minimize how much healthy bowel I'm going to lose. And then use the enterotomy to fix the anvil in place. and turn that up there. Now I'm going to use the disconnection of the bowel, and you can see the devascularized bowel is purple, and then when I reach the healthy bowel, that's pink. We also use ICG to check the vascularity of the bowel wall, so that when we're stapling, our two ends of the bowel are going to be well vascularized. So we retrieve the specimen through the open vagina, make sure we're not suturing the ureter when closing the vagina. That's why I keep switching to ICG in the middle. If anybody wants to know, I put ICG into the ureters with a 10 ml dilution in normal saline, and stain each ureter with about 5 ml of dye, which stains the mucosa. There's no stents in the ureter, and that dye will stay for up to 12-14 hours as well. So we finish the anastomosis, check the vascularity of the anastomosis, and that's the safety tests. And once we finish excising, we see that the ureter is well vascularized. It's gaining, the hydroureter is reducing. So we chose to just stent this and keep it in place. So we avoided a reimplantation as well. Now, of course, if you see this, we're looking at a bowel nodule here, where we have one nodule here. And as we look further, we see a second one there. We confirm the same findings on the MRI. And I think I'm going to skip the video because of the time we have. So you see the same steps as before. It's a bowel resection at the end of the day. I'm not going to waste too much time with this video and how it's prepared. We finish the resection again, and this is what the specimen looks like. So two nodules in very close proximity to each other. And then finally, this is another example of a double nodule. And this is a type 1 nodule, and you see this was closed. So we have 1 and then 2 right there. Now, speaking of MRI, we use T1 and T2 sequences, as well as what we do is we use gel in the vagina and the rectum. Now, what we need to know for the MRI is that T1 and T2 weighted sequences. T2 is your main. That's the first thing I look at. So we look at T2 weighted sagittal and axial views, and sometimes the coronal section. And in this is very good for looking at pathology. And if you see, I've color coded this in different shades of white and gray and black. So your fluid and pathology will be white. Fat will be white as well on T2. And we have some fibrosis, which will be darker gray, and then some acute blood there. But when we want to look for hemorrhagic contents, we look at T1 sequences. So that is going to look at blood. And where we differentiate between blood and fat is when we look at fat saturated, which takes out the fat. And then we get a nice T1 fat saturated where everything white will be blood. So we look, these are the sagittal planes on an MRI. We need to understand the difference between a rectovaginal septum and a retrocervical septum. So that's what we need to study in terms of the MRI. And also at the torus, that's where your uterosacral ligaments will emerge. These are what normal uterosacral ligaments look like on an axial view. And obviously with most evidence, it's heavily dependent on the operator. So it's going to find no difference between the two. In my personal opinion, MRI is useful for looking at nodules higher up in the bowel and more lateral nodules, so in the parametrium and so forth. And here you have a cyst, and of course you can see there's a nodule in the rectum right there. The same nodule on the coronal view, we see an almost subocclusive nodule, and both the ovaries are kind of pulled back as well. And then in the axial view, you have this large infiltration here stuck to the right ovary. Here's that double nodule we had seen earlier. And here's a very nice example where we had seen a nodule on an ultrasound, described a single 3 centimeter nodule. But when we looked on the MRI, we see another one up here, and another one, and another one, for a total of 5 nodules in the bowel. This patient also had the appendix, the cecum, and an ileal nodule. So she required a hemicolectomy as well. So these are some case examples of how it looks like. So you see a small retrocervical nodule there. And yeah, if you look at the axial view, I've taken a couple of motion images here. That's the cervix. And what we're looking at there, that's the vagina below, that's the rectum. And here, the rectum is free. But you see the rectum gets stuck, and you see this little mushroom-shaped structure here. That's the nodule. Similarly, on the axial view, when we move from left to right, what you're going to see is that's the oma, of course. When you see the shading here, that's the same oma in the axial view. So you see the shading there because blood separates into different densities. And here you see the rectum stuck to the back of the uterus, right there, which is where we decided it's not too deep into the muscularis and we can shave. So we'll skip the video because it's a very typical shaving technique. So this helps us discuss our surgical plan. Now, this is a patient where I chose to be conservative and leave the bowel nodule in because she had no bowel symptoms. And you see this big left adnexal mass and this large endometriosis nodule in the rectum. And here, if you look at the imaging, she had a pretty large nodule, and you'll see it's quite extensive. But amazingly, she chose, we discussed the option of performing a resection. So you see there, and it's going higher up as well. So she had almost 12 centimeters or 13 centimeters of bowel involved. And then you had this big mass. So chose to go under medical management, and she's unfortunately become symptomatic all of a sudden now recently. This is almost 3 years ago, and then we'll need to proceed with the resection now. So you see there's the nodule across, and as we go higher, we can see it through and through. As we follow, that's the nodule. And this is once we ascend the colon, we'll be able to see the rest of it in the axial view. These large nodule infiltrations, so it's going across there. I was quite amazed that she had no symptoms as such. And as you see, the sagittal view is much nicer to appreciate this. So if you see here, this is the same patient that with that left-sided mass, and we see this is the whole nodule. It formed a bit of an omega and going up there. So it does not look very obvious, but when you actually pull away that retraction, it's a very severe nodule. Now, when we have obviously a big primary, we had seen a specimen picture of this earlier where we have that double nodule. We'll look at this on the MRI. So here you see that's the bladder in front. And as we move in, you'll start to see the uterus up here. And when we follow the rectum, you see this is the nodule 1 and 2 nodules right there in the rectum. Okay, she's obviously had a shaving done. So somebody had shaved off a huge portion of the cervix. That's why the cervix is looking quite thin there. What was supposed to be a retrocervical nodule, but the bowel nodule was left behind. Of course, she was going to be vastly symptomatic of that. And here we have the cervix and the rectum below. And when we see, this is the rectum that's free. And as we go higher up, you start seeing the infiltration into the rectum right there. It's stuck to a left oma. And as we go higher, we have another infiltration there. Okay. So this, you can see she has an infiltration into the vagina posteriorly. So we had to excise that portion of the vagina. And this is the nodule where there are 2 nodules in the rectum. So surgery before ART, of course, I think Horace will discuss that in his lecture on colorectal endometriosis. This one is where she was reported as just having an endometrioma. And of course, as we see, it's never just an endometrioma. If you look, we have an infiltration into the left uterosacral ligament where the rectum is stuck as well. And if we look on the MRI, so this is a little different from bowel endometriosis. So you see there's gel in the rectum, gel in the vagina. And going further, there is no rectal infiltration per se in her, but you see you have this large infiltration into the left uterosacral ligament here, to which your ovary is stuck. And then there's a slight infiltration towards the uterosacral and the parametrium on that side. Not massive, but quite significant. And also in a coronal section, so the abdominal muscles, that's the bladder. That's the left ovary. And as we look deep to the ovary, that's the gel in the vagina. So you see we're at the cervix now. And just here is where the uterosacral ligament will be infiltrated. And that's where the rectum is kind of stuck to that as well. Okay. Now this is the same patient. We'll skip the video again. So points to discuss on this is, there's a very interesting paper from JMIG, is that most radiologists are not trained to identify deep endo. There are protocols coming into place now. So if you ever have a report saying that it's just a cystectomy, you would be grossly underestimating the disease, because an endometrioma never exists by itself. Up to 75% of patients with omas will have deep endo.
Dr. Abhishek, again.
Yeah.
Sorry, can you just speed it up?
Yeah, this is the last one.
Yeah.
Okay, so okay, we can skip this one, and then of course we have to talk about kidney loss. So always also when you see an hydroureter, always look at the kidneys. So we have this big oma over there with a big parametrial nodule, and then as we see, as you scan higher, there's the hydroureter on the left, but you see his big hydronephrosis as well. And she had a 3% kidney function, so we have to perform a nephrectomy, uretrectomy, and parametrectomy as well. So I will just conclude my talk with saying that the correct diagnosis of endometriosis is the key step to avoid having patients undergoing revolving door surgeries, and also to be able to counsel them in the OPD as to what is necessary for making sure your surgery is going to be successful, and to reduce your recurrence risk, where we are able to reduce recurrence rates by removing the disease as completely as possible. So thank you for your time, and I'll switch over to the next speaker.
Yeah, thank you so much, Dr. Abhishek. That was an excellent presentation with great correlation with our imaging also. And then it was, I think you'll have lots of questions, so please do stay back. I think Dr. Benjamin and Horace have a congress to attend, so we will not waste their time. So please stay back for the discussion at the end of the
Okay,
session.
I'm going to see a patient very quickly, but I will join back after that within their talks.
Okay.
Thank you.
Thank you.
Bye-bye.
So hello,
See you
sir.
soon.
Dr. Benjamin, welcome to the webinar. Dr. Niveda, can you please introduce Dr. Benjamin, please?
Yes, ma'am.
Yes.
Slides, please.
Sahiti?
Yes, ma'am. I'm sharing. Just a second.
Yeah, so Dr. Korean sir has left because he has some emergency. So I'll moderate the session. So you can introduce the speaker. Okay.
Okay, ma'am. So it gives me a great pleasure to introduce our next speaker, Dr. Benjamin Merlet. So Dr. Benjamin Merlet, sir, is an endometriosis surgeon, co-founder of IEF Mendo and medical director of the Center of Endometriosis, Bordeaux, France. He's a co-founder of IEF Mendo Middle East Clinic, one of the rare surgeons in the world which surgical activity has been exclusively reserved to endometriosis for more than 10 years. He's a coordinator of the pathway management with the French regional Nouvelle Aquitaine Health Government. He's a member of European Endometriosis League, of the Society of Endometriosis and Uterine Diseases, and member of board of the French Society of Gynecological Surgery. He is a certified surgeon of excellence in multidisciplinary endometriosis care, and IFE Mendo was certified center of excellence in multidisciplinary endometriosis care, COMEC 2019 to 2026. His memberships are European Endometriosis League, Society of French Gynecological and Pelvic Surgeons, Society of Endometriosis and Uterine Disease. He has published more than 70 scientific articles related to various surgical approaches and the probability of postoperative natural conception following surgery for deep and ovarian endometriosis. Over to you, sir.
Thank you so much. Thank you so much.
Hello, sir. Welcome.
Thank you. Happy to be with you today.
Yeah.
It's an honor to join you to this wonderful wonderful topic. So I'm very happy to be here and to see some friends like Prashan and Abhishek. So happy to be there.
Yeah.
Many greetings, Benjamin.
Yeah.
Thank you so much. Sorry for my English. I will do my best, but I am French.
And me.
So we can start. I will. Horace, my friend, how are you?
Yes, you seated all your friends excepted me. I didn't see you.
Yeah, good evening, sir.
Come on now.
So time to, sorry, because I am here in Paris in a French surgery gynecologic congress. So I will have to finish after and to go to the next session. So I will just do my topic, and after I will have to go. So let's start. I will turn my screen. And okay. Is it okay for you?
Yeah. It's perfect.
So let's speak about one of my favorite surgery, the diaphragmatic surgery for endometriosis. I will just introduce the topic because it's probably underestimate lesion. We think we have 2% of patients who have pelvic endometriosis, who have a diaphragmatic surgery, diaphragmatic endometriosis, sorry. And in 90% of cases, it's on the right side only. The lesions are multiple. In the 70% of cases, you have a lot of superficial and deep lesion on the right diaphragm. So the diagnosis is not so easy because the patient have most of time right pain, shoulder and neck pain on the right side. The pain is worst during catamenial periods, or you can have catamenial pneumothorax, but you will see the problem is managed usually by thoracic surgeon in case of emergency. You can have a symptom about diaphragmatic hepatic hernia, like difficulty to breathe. And the problem is, as the pain is not on the pelvis, the patient don't understand they can have endometriosis on the diaphragm, and it's difficult to the doctor to diagnose the patient. So you have big diagnostic delay, and it's difficult to diagnose it. So most of time, you can see it during a laparoscopy, diagnosis laparoscopy, or if you do surgery, pelvic surgery for pain, and you will see the endometriosis on the diaphragm. Why is it difficult to diagnose this? Because of the anatomy, because the pain comes from the phrenic nerves, and I will show you normally. You can understand. This is the diaphragm. You have a part of the lateral part is a muscular part. The medial part is a tendinous part. It's very thin. And the innervation comes from the phrenic nerves. You will see it. And it comes from the fourth cervical vertebra. And it will mix with other nervous fibers come from the shoulder. So you have pain in the shoulder, and the problem is on the diaphragm. Okay, so we have to know this anatomy in case of indication of surgery. You have two dangerous parts: the phrenic nerves, the liver, because can have a very easily traumatic lesion in hemorrhagia, and the sushepatic venous. You have to know this anatomy before to do this type of surgery. So you can have superficial disease, okay? You can manage by plasma, electrocoagulation, or you can remove by just to do small superficial surgery, okay? Like you see on this video, okay? You can remove by ultracision too when you have superficial disease, okay? You will not be, or the nodule is not completely involved the diaphragm, and sometimes you have deep endometriosis on the diaphragm with a complete involvement of the muscle. You have to remove a part of the diaphragm. And in this type of surgery, we like to use a robot because it's a small area, difficult access, and difficult to do the suture. So most of the time we use robots, okay? And we remove completely the nodule, completely the part of the diaphragm is involved. And we will see, like this surgery, the thorax and the lung. You have to avoid the risk of injury of the lungs. Okay, you can see the thoracic part. You can put the camera and the 30 degrees. You can have a vision of the thoracic part of the diaphragm like this to be sure you are complete. Okay, and you can remove more. Okay. That's why we like to use a robot. And you can do like a thoracoscopy by abdominal approach. And it's completely different by thoracic approach because it's less painful. So first part is to remove. Second part is to suture. So usually we use continuous suture, okay, with in the first surgery only resolvable stitch. Now we use both continuous suture and mer suture. I will show you. And you have to remove not the pneumothorax, it's a capnothorax with CO2. So you have to remove the maximum of the gas. So we use a drain. You put the drain, you ask the patient, you ask the anesthetist to breathe a lot, big inspiration to remove the maximum of gas, and you see the diaphragm come back to the lung, and you finish your suture. So this is a typical case, easy case. Most of the time is most difficult than this video, and you remove the part of the diaphragm. So usually you have superficial and deep lesion, and when you have deep lesion, you have to remove by a partial section of the diaphragm. So just some words about the exposition. So it's more easy to do surgery in lateral decubitus, like the patient, to have a great access to the liver and a great access of the posterior part of the liver to the diaphragm. So with this position, you will be fast. You don't have the necessity to cut the falciform, the falciform ligament of the liver, and you can do great and a great exposition surgery. So every patient will use this position, and you will use a robot to perform this type of surgery. This is the same patient. I will go back. I will show you some other surgery. So I show you a simple surgery first, and I will try to show you some different kind of surgery, more and more difficult. So I told you sometimes the symptom is a hernia, diaphragmatic hernia, like this patient. It's easy to see on MRI, okay? And you have to do surgery about the patient because most of the patients have some difficulty to do sport, difficulty to breathe. And you have a part of the liver go through the windows inside the diaphragm of endometriosis and go inside the thorax. So you see easily the hernia. Okay, so first part of the surgery is to remove the liver from the thorax. Okay, you have, like usual, a lot of lesion, not only one. So it's a blend of endometriosis of the diaphragm and the big windows. Okay, so first we have to release completely the liver to have enough free diaphragm to have a no tension suture. So first part is to find a safe plane to plan your suture, okay? Second part is to remove the part with the windows and the endometriosis. So you see the lungs just behind the diaphragm. So we remove a big part of the diaphragm, okay, or the part with the disease, and we start the suture. So you see it's a small area. So using the robot is very, very helpful, especially for this kind of surgery. And at the end, like usual, we remove the gas, and you see the suture. Other example, this surgery was a recurrence. The patient was managed by the thoracic surgeon many times with a catamenial pneumothorax, drain, recurrence, drain, and they finished by do a thoracoscopy, removing a part of the diaphragm with only a view on the thoracic part of the diaphragm, who usually is less involved than the abdominal part of the diaphragm. So it was not a complete surgery by the thoracic surgeon. And at the end, as usual, they do pleurodesis, talc pleurodesis, with purpose to stuck the lungs again the diaphragm. So for your surgery by abdominal approach, if the thoracic surgeon did first the surgery, your surgery become difficult and dangerous. So I will show you a case. So this is a recurrence. The surgery was not complete, and the patient keep to do pneumothorax. Okay, and you see the parts we was managed by the thoracic surgeon. Lot of adherence and a small window. So you see the lungs is very close the diaphragm. So when you open the diaphragm, the lung is just behind. So the danger is dangerous because you can do injury of the diaphragm and have a real pneumothorax and have the necessity to put a drain, a thoracic drain. So you have to be very careful with the diaphragm to release the liver to have enough space to close. So you see the adherence because of the pleurodesis first between the diaphragm and the lungs. And at the same, you remove the part which is involved. Okay, You see, it was cause of the first surgery. And remove all the parts with the disease. And you will see the staple of the first surgery. Thoracic surgeon do remove a part with a stapler. And you see the stapler of a linear stapler, and you see the stapler of the first surgery by the thoracic surgeon. So same, remove whole. The objective is to be complete. So you see the lungs is not so far because of the adherence. And we close by V-lock, okay? And we have separate stitch more, no resorbable to have a strain suture, okay? And you see at the same, we remove the gas and you see the result at the end with no windows and complete surgery. A rare case, as I say at the beginning of the topic, the lecture, most of time it's a right lesion. You can have some patient with left lesion. It's very, very rare, like this patient. She have first hemoperitone, big hemoperitone. Another team do a laparoscopy diagnosis. They see a bleeding come from the left diaphragm. You see spleen. And the MRI confirm endometriosis on the diaphragm, the left side. So you see, because of the first problem with big hemoperitone, the liver is completely stuck to the diaphragm, you see, completely. So first we have a big time of releasing and separates the liver from the diaphragm. This is a difficult part with lot of adherence. So we have some bleeding from the liver. Finally, we find a soft and safe plan. We separate the posterior part of the diaphragm from the liver for the same, and the part which involved is somewhere here. It's difficult to see, but somewhere here. So same, you will open to push the lung. Okay, so you see the lung, and you will see at the end, we are very, very close the pericard. So we have to be very careful in case of surgery of the left diaphragm, because you have not only the lungs, but you have the pericard with very, very close. And the results at the end of the surgery. Sorry. I have a problem. Oh. Okay, sorry. So be careful, because you can have isolated thoracic side endometriosis. Just to show you some picture, it's a patient with a typical symptom of right diaphragmatic on the diaphragm with a pain shoulder, and the MRI show a small spot 6 millimeter from the right diaphragm. And when I did the laparoscopy to remove it, the diaphragm was completely normal. No windows, no superficial endometriosis, nothing. So I hesitated a lot, and I finished by open the diaphragm to see something inside the thorax, have a thoracic view, and have a thoracic view of the diaphragm. And finally, we find the endometriosis only on the thoracic part of the diaphragm. So you can have some case with a complete normal diaphragm, and the visible lesion is only on the thoracic view. Okay, so we remove, and the patient was free of pain after the surgery. We have some limits about the mini-invasive surgery and using the robots. You have some case with a full involvement of the diaphragm, well, big parts, And when the lesions are more 12 centimeter and 7 centimeter, perhaps it's difficult to use a robot. You arrive on the limits of the anatomy and very close to the subathepatic venous. And for example, in this case, we have to do laparoconversion to remove a big part of the diaphragm and to put a prosthesis. This is the thoracic part. You see a full involvement of the big part of the diaphragm. You see 15 centimeter, okay? So in this case, we have to do laparoconversion and we have to put a biologic prosthesis, okay? It was not possible to close by a simple suture. So we have to put a prosthesis to limit and to close. So just a last slide about her experience. So we have more than 100 cases. You see the operating time it's very low. We have a lot of time to install the patient, to put on the lateral decubitus, a lot of time to do a great anesthesia, but the procedure time, skin to skin, it's 1 hour. Okay, the patient come back at home 1 day after the surgery, between 1 day and 2 days, and we have one perioperative complication with injury of the liver with a conversion, and we have 3 cases of late suture failure with sometimes a small hernia. 2 years, 3 years after the first surgery, you can have a kind of leakage of the of a failure of the suture, and you have to manage by a new surgical approach. Just to finish, I will show you a surgery to manage a late failure of the suture with a hernia. It was my patient, and it's difficult to manage by robotic and no by laparotomy, because you have a lot of adherence because of the previous surgery. So you have to find the plane between the diaphragm same and the liver, but you have a lot of adherence. You start to see the hepatic hernia, the liver hernia, sorry. Okay, through the diaphragm. So easy to find the anterior part of the diaphragm. It was difficult to go behind the liver to find the posterior part of the diaphragm because the hernia was big, as you see. So usually it's take 1 hour for this patient. It was between 3 and 4 hours of surgery. So you release the adherence between the liver and the thorax and the lung. And finally, we find the posterior part of the diaphragm with a lot of difficulty. Okay, we remove the part, and we have to put a mesh because you see it's a big hernia. Okay, it's impossible to close without tension. So same, we put by robotic approach a prosthesis to close the diaphragm. It was impossible to close, and we was afraid about the recurrence of the hernia, so we closed with a prosthesis. Thank you for your attention.
So, yeah, thank you so much, sir. That was a great insight to diaphragmatic endometriosis. Wonderful videos.
Thank you.
So then the last case, like what tape have you used to suture to close the rent?
What kind of prosthesis we use?
Yeah.
It's a collagen. It's a biologic collagen prosthesis. Very, very expensive. In France, it's 2,000 euro. Because we use it, but it's very expensive. So we use few in case of big resection or in case of recurrence of hernia. Yeah.
Okay. So many times we are not diagnosing diaphragmatic endometriosis pre-operatively. Only during the surgical procedure, we are seeing some faint dots here and there. So
no, we ask in consultation, we ask the patient directly if she have pain on the shoulder. Sometimes they have, sometimes they have not. Sometimes the MRI don't see well this part because if we have a superficial disease, the MRI don't see it. Okay, so yes, you have a lot of cases with diagnosis the diaphragmatic endometriosis by laparoscopy during a pelvic procedure.
Okay, so what is the best diagnostic modality? So MRI also,
MRI.
none of the people report diaphragmatic endometriosis.
Yeah,
What?
the best is MRI with coronal cuts, and you can have a superficial, you can see, but you can have normal MRI and superficial endometriosis on the diaphragm. It's usual.
So what is the point that we have to decide whether this particular patient has to be the endometriotic lesion has to be excised, or we can just leave it like that and come?
You can have many cases, okay? You have patient with no symptom, especially
no
if the
symptoms.
patient take pills with amenorrhea. So it's only a surgery for pain. So if patient have no pain, you can perhaps don't perform surgery. Just sometimes we are afraid about the risk of pneumothorax, catamenial pneumothorax. Okay, but if patient have no symptom, no surgery for me. Some exception, okay. And if you look the pelvic, if you do surgery for the pelvic endometriosis and you find diaphragmatic endometriosis, I think you think it's superficial, you can manage in the same time, okay. But I think if you see a big lesion on the diaphragm, we advise to do surgery in the second step by robotic surgery only on the diaphragm.
Okay, so if you're not prepared for the excision, it is an incidental finding. Is it okay to just cauterize those lesions under the diaphragm?
Sorry, I don't understand.
You have not been prepared to operate on that particular lesion. And is it okay just to cauterize with a bipolar, the endometriotic lesions under the diaphragm?
Yeah, if you think it's only superficial, if you think it's deep,
yeah,
it's and you have to understand that the diaphragm is very, very thin, and we have some case with only electrocoagulation, and we see the patient two years after with a hernia. So be careful. Okay, so electrocoagulation is okay if you have only very superficial disease on the diaphragm.
I think Professor Horace has to say something. He's raising his hands. So one more question, after the surgery, will the patient have any kind of respiratory discomfort because you are excising a portion of the diaphragm? Will the patient have any kind of discomfort, respiratory discomfort?
Yeah, you have some gas keeping in the thorax the day after the surgery. So if patient have some difficulty to breathe, but usually it's very fast to be comfortable and you have nothing to do. If you do a radiography the day after the surgery, you will see a kind of a small pneumothorax. But if the patient have good breathing, good saturation in oxygen, it's okay. Don't worry. It's the gas is the same we use for the pelvic surgery, for abdominal surgery. So it will be resolved like your laparoscopy. So
okay. So you mentioned that it is more common on the right rather than the left.
yeah,
diaphragmatic endometriosis. Is it anything to do with the peristaltic veins? Why is it more common on the right?
it's the same. It's the same reason than the carcinosis of ovarian carcinosis, because you have the liquid fluid, the peritoneal fluid liquid, and you know the right colon don't block the liquid fluid. Okay, so go on between the liver and the right diaphragm, and the left colon, the sigmoid, okay, block the fluid, so you don't have on the left side. And you have more lesion of the left colon, sigmoid, than on the right colon, okay?
Have you seen any recurrence after excision in diaphragm? After your surgery?
I think no, we have no recurrence. We have only 2 or 3 patients with a failure of the suture, but I think we have no recurrence. Horace, do you have a recurrence of the diaphragm?
I do not have recurrences, but right now I have 2 patients with recurrent pneumothorax. And one of them, I saw her yesterday. It's a story we do not understand because I cleaned completely the diaphragm and I excised with suture in January. She has had hysterectomy, so there is no communication with outside. And she had a new pneumothorax, very small, but a pneumothorax visible on the radio of the X-ray. And this woman, I cannot understand where the pneumothorax come from, how it occurs, and I don't know very well how to propose except to continue appeal and to see.
Okay. So will these respond to any kind of medical management, the diaphragmatic endometriosis? After removing the ovary, the uterus, and all the thing, I mean, after the pelvic endometriosis have been removed completely, do they respond to medical management?
After removing all the endometriosis?
Yeah, this diaphragmatic endometriosis.
I think if you are no reason to keep a medical treatment, no pelvic reason, you have no reason only on the diaphragm.
Okay.
I think the risk of recurrence, if you do a complete resection of the diaphragm, is less than pelvic endometriosis.
Yeah, thank you. Thank you so much, sir. Prashant, sir, do you have any questions? Okay, so I think it was a great presentation, sir. Thank you so much for sharing your valuable time and also your knowledge. Your surgeries were so amazing. So we really benefited so much from your workshop. So I really wanted our colleagues from here, India, also to have a look at your excellent surgical skills. And Dr. Horace, and you are doing a phenomenal job. So thank you so much for your time and coming in midway between your conference and participating in our webinar. Thanks.
Yeah, thank you so much, and sorry to have to go, but thank you so much. It was a great honor to be with you. Horace.
Thank you, sir.
Bye-bye.
Yeah.
Enjoy the Congress.
Thank you.
Yeah.
And speak about what we are doing.
Every day.
So we move on to the next session. So I'd like to invite Dr. Niveda to introduce our next chairperson and request Prashant sir to introduce our speaker, Professor Horace Roman.
Yes, ma'am. The slides, please. So it gives me a great pleasure to introduce our next chairperson, Dr. Prashant Mangeshkar. He is a president of Asia Pacific Association of Gynecological Endoscopy. Sir was a past president of International Society of Gynecological Endoscopy, past president of Indian Association of Gynecological Endoscopists, was a global director of International Society of Neuropelviology. He was a pioneer of advanced laparoscopic surgery in India in 1985. He was the first to perform TLH in India and Asia in 1991. He developed Mangeshkar uterine manipulator for TLH and several instruments for laparoscopic surgery, as in knot pushers, needle holders, and grasping forceps. He has developed the technique of laparoscopic Mangeshkar cervicopexy for uterine prolapse in young women in 1991. He's a consultant gynec endoscopic and robotic surgeon at Breach Candy, Jaslock, and Safety Hospitals, Mumbai. Sir is a faculty at Irkad, Strasbourg, Jason School, and Kiel School of Gyn Endoscopy, Germany. He has conducted more than 150 workshops in advanced laparoscopic surgery in 91 countries till date. So we would request you to invite the speaker, sir.
Thank you for your kind introduction and also for the invitation by Mala to be here. And of course, when you said that Horace and Benjamin are going to be there giving their talks, I said, well, I cannot refuse this offer. And it's always nice to see my friends. This time, though not in person, we met just 2 weeks ago, but now to be even across internationally online and see them and hear them, it's been a great pleasure. I always say that you're not a complete laparoscopic surgeon for endometriosis surgery if you haven't been trained by Horace and Benjamin. So that speaks of their center and their work. Horace has been a great man, a human being, excellence with fantastic skills in laparoscopy and robotic surgery. He's been honorary professor at AUS Medical University, Denmark. He's had the honorary causa offered to him by the Medical University of Bucharest. He's had deep, he's well known for his work on deep endometriosis, and he practices at not only in Tivoli, at Ducos Clinic in France, but also in Cluj as well as in Abu Dhabi. He's a certified master surgeon of excellence in multidisciplinary endometriosis, and his center, Ifimendo, was certified as a center of excellence in multidisciplinary endometriosis care. Been a member of the World Endometriosis Society, the EEL, and the French Society of Pelvic Surgery and the AAGL, received many awards and published thousands of papers. I forget the list because it just grows every week. And I'm amazed how he's got such energy to write papers after doing fantastic surgeries, almost 3 to 4 minimum a day. So without much of a delay, let's have Horace talking now on bowel endometriosis, a subject that is very near and dear to him. Horace, the field is yours.
Thank you, Prashant. I'm honored, and I am always amazed how you present me, and I would like to invite my daughters to hear you, to listen to you.
We will send you the recording. Don't worry. And I'm not joking. I'm very factual in whatever I say, good or bad, and there's nothing bad about you. Everything is excellent, you know. And
okay.
I need to take time off from my work. My boss is giving me permission, not the one on your shirt, but my boss at home is giving me permission to spend time with you. So I will come.
I see your second boss in the right corner, Abhishek. Hi.
See you.
Okay, so it is a great pleasure, as always, to be with my Indian friends, because we actually built a wonderful friendship with Prashant, with Abhishek, and with almost 100 Indian colleagues who visited us in Bordeaux. And with Benjamin, we were always very, very pleased to receive you because when compared to European or American or other country surgeons, I am always surprised how very, very skilled surgeons can be humble and interested to learn. And Prashant is the perfect example how they represent the say that the learning never stops. So I will speak about the bowel endometriosis, which is one of my favorite topics, and I will start just by recalling you, because I'm sure that most of you have already heard a lot of information I will give you, that the endometriosis of the digestive tract is not uniformly spread on the several methods of digestive tract, but in 80 or even 90% of cases, it involves the rectum and the sigmoid colon. In 5 to 6% of cases, the cecum, the appendix, and the last, let's say, 30, 40, 50 centimeter of the ileum, while other segments, such as the duodenum, the liver, or the stomach, are very, very rare, if ever, involved by endometriosis. You know that when we speak about endometriosis surgery, we speak mainly about two big philosophies, two big approaches. One is the conservative surgery, conservative approach, which means that we try to remove the nodules without removing the segment of the bowel which is infiltrated by the disease. And we can do this by shaving or disc excision. And then we have the radical surgery, where we cut a segment of the colorectal resection and we remove it together with the lesions. It is the segmental colorectal resection. So these two approaches have fighted each other for years. So those who participated meetings in 90 or 2000 until 2010, 2015, remember how Jacques Donez and Philip Koenigs were fighting to do always shaving, while other guys such Professor Chaperon are saying, no, nothing works except the segmental resection. Now, I think the new generation is much more shared between the techniques, and you will see we in Bordeaux, we do the free techniques and we try to adapt them to each patient. So in outlines, the shaving means that you remove the nodule without opening the bowel, the rectum. The disc excision, you go a bit farther and you remove the piece of the wall which is infiltrated by the nodule, and then you suture the hole. And the segmental resection, of course, you cut up and down, proximally and distally from the nodule or the nodules, and you remove a piece of the rectum. So I told you that at IFEMENDO means me, Benjamin, you have already heard him, me, Benjamin, and another three colleagues, surgeon colleagues. So we have IFEMENDO Bordeaux, which is our biggest center, and then we opened IFEMENDO in Abu Dhabi and IFEMENDO in Romania. So everywhere we do the same procedures. So at IFEMENDO we have a database, and we record in the database maybe 80 to 90% of our surgeries, not all the surgeries, but we miss some surgeries. But anyway, this database allows us to have a good idea about what are we doing. And in this database, from September 2018 to September 2025, including the COVID period, we recorded 2,029 digestive tract endometriosis. And as you can see, we have almost 500 shaving, meaning 25%. We have almost 600 disc excision, meaning almost 30%. And we have colorectal resection. We have colorectal resection and 372 nodes, which is a variant of colorectal resection. So nodes are not included in the colorectal resection, of course, which represents almost 50% of surgeries done by colorectal resection. So 20, 30, and 50%. Then we have another procedures, resection of sigmoid colon, resection of ileum and ileocolonic resection, excision of the cecum. Anyway, but you see, we are not fighting to do only one technique, and because one technique cannot fit all the patients with all the nodules. Now, if you speak about each technique, the shaving means that we try to remove this nodule without opening the mucosa. We can use scissors, laser, plasma, harmonic scalpel, robot, whatever you wish. The goal is the same, to try to remove as complete as you can the fibrosis, the endometriosis, and not to open the mucosa. Very recently, I saw a technique by Danny Shu, who's an Australian surgeon, who injects blue methyl, which separates the mucosa from in the submucosa, and which separates the mucosa from the muscularis. So he preserved better the mucosa, and then he sutured the edges. A very, very good technique, wonderful technique. He published it in GMIG. Anyway, you have to be aware that if you do a shaving, in almost all cases, you leave some endometriosis on the bowel. Because the goal of the shaving is not to open the bowel, so the surgeon will do everything he can to not to open the mucosa, and to do this, he will leave some parts of some tissue saying, no, it's not fibrosis, it's just fibrosis. So anyway, in almost 100% of cases, the shaving is not microscopically incomplete, which explains why the rate of recurrences is maybe higher than those observed after disc excision or rectal resection. But it does not mean that the shaving should not be used, because the advantages of the shaving is the very, very low rate of complication, because if you do not open the bowel, you have no, you do not increase the risk of infection of the pelvis. Also, as you do not remove a piece of the rectum, you do not expect an impairment of the functional outcomes. So we privilege it. We do most of our shavings in elderly women where the risk of recurrence is lower because of the delay until the menopause. And we frequently recommend a pill after the surgery in order to induce an amenorrhea and to avoid any recurrence. So we extensively assessed the bowel function after the shaving surgery, because as we have this database with 2,000 endometriosis, the patients enrolled in the database or recalled every 2 years by a clinical researcher to fill in questionnaires, so we know how they are doing far from the surgery. So we observe that even though the excision is always incomplete, we have a very low rate of complication, never worse functional outcomes. Maybe we relieve less the constipation, maybe we have more recurrences, and we employ it at first light technique. Each time it is feasible and satisfactory because there is an improvement of function after the shaving. So the shaving, it's a good technique. Now you have to choose it in right patients. Opposite, we have the colorectal segmental resection. The advantage of the colorectal resection is that it is very standardized technique. So when a colleague say, I did a shaving, I never know exactly what he did, if he removed everything or just half or just 10%, if he left the nodule inside the lumen. So I need to do an MRI to understand what he removed and what he left. Conversely, when a colleague tells me I did a colorectal resection, I removed 10 centimeters of the rectum, and I carried out an anastomosis end-to-end 6 centimeters above the anus, I understand what he did as I were there. So it's a very standardized technique, and all the colorectal surgeons involved in multidisciplinary procedures to do this, all the colorectal surgeons know very well how to do it. However, we reserve this standardized technique in only huge subocclusive nodules, in nodules responsible for a long bowel infiltration where we cannot do a disc excision, in circumferential lesions where, again, we cannot shave or do a disc excision, and in multifocal rectal lesions which are closed. We cannot treat them separately. The problem of the rectal resection is that even though you remove everything you see, you can sometimes leave microscopic foci outside the limits of the resection. And the biggest problem of the rectal resection is that it can be followed by the LARS. LARS is the low anterior rectal resection syndrome. We'll speak 10 minutes later. And this is the major functional complication of this surgery. Also, particularly in surgeons who use the preventive stoma, the colorectal resection may be followed by a stenosis of the anastomosis, which should be treated separately later in order to dilate, because the anastomosis may be as narrow as a couple of millimeters. Now, at this moment, we are carrying out the nose. So in our database, there are almost 800 colorectal endometriosis classical with incision, suprapubic incision, and there are almost 400 nose. Nose means natural orifice specimen extraction. And it means that we do not open the abdomen, we do not do the suprapubic incision, but we cut the rectum and we'll extract it either through the rectum itself or through the vagina if the vagina is opened. And this technique is very, very smart and even faster than the technique using suprapubic incision. And you will see how it works. So here we have a big lesion of the sigmoid colon. And what are we doing? We cut, we separate, we cut the mesorectum, we cut distally with a stapler the rectum, we cut with scissor proximally the sigmoid colon. We retrieve everything through the vagina because we also did a hysterectomy. We retrieve the rectum through the vagina. We introduce the anvil through the vagina. We place the anvil and we carry out the purse string, and then we do the anastomosis end to end. It can also be done side to end. Anyway, the goal is not to open, not to incise more than 12 millimeter the abdomen, and to use either the rectum or the vagina to retrieve the specimen. So here we had two nodules, not far each other. That's why we did not treat them separately, because the healthy colon between the two lesions was too short. But my favorite technique is the disc excision. The disc excision can be considered a conservative approach because we do not remove the piece of the bowel, we remove only the area which is involved. So it means that we carry out the shaving and then the shaved area is removed with the opening of the bowel. The advantage is that the technique is more radical, more complete than the shaving, but reported to rectal resection, we do not need to go behind the rectum to section the mesorectum, and we do not shorter the rectum and the rectal ampulla. So we shorten the anterior wall, so we have a posterior wall which becomes larger with a kind of posterior rectal cell, but this rectal cell has, in our opinion, no impact on the function. Furthermore, we have never observed a stenosis after this suture, which is only semicircular. We published a lot of papers. I think there are at least 45 articles in the literature written by me with the keyword disc excision. So it is a technique, I know it by heart. And I think maybe I am the guys who has already done the highest number in the world, which is not the most important. I want to just suggest to you that I know it very well. And I liked it very much. So our team published the longest series done in Bordeaux. You have to imagine that in Bordeaux we carried out 574 recorded in the database, and me, I have done 200 before 2018. So we have an experience of almost 800 disc excisions. And in all these patients, we had a very low rate of recurrences, which is 1%, 2%, something like this. The technique is like this. So we carry out the shaving, then we introduce the transanal circular stapler closed. We open it in order to push the shaved area inside, and then we close and fire, and we remove a disc and we leave a semi-circular suture. It is very, very efficient. And I will just show you how it works in very, very large nodules. So here we have a nodule more than 4 centimeters on the mid-rectum. So in this case, if you perform a characterization, you have to go down to leave a suture at 4 centimeters above the anus, which is quite low, and to remove almost all the rectal ampulla. In this case, you may have functional unfavorable outcomes. So what we do, we separate the rectum from the nodule involving the vagina and the torus. So we cut the nodule in 2 pieces, one of the rectum, one of the vagina, and we look for the healthy rectovaginal space. And you see here we have the infiltration. And you see maybe 3 centimeters, but the nodule is much larger because it is almost occlusive, meaning that if we do the shaving, if we remove the nodule and we release the mucosa, we'll see that this area of the infiltration of the rectum will increase up to 5 centimeters. So we do the shaving on contact with the mucosa. We try to avoid to perform a hole into the mucosa, but if you do it, it's not a big deal. And progressively, the rectal wall will become soft. And this is very important because we have to put it into the stapler. And if the nodule is inside, the stapler cannot close on the nodule. It can close only on the very soft shaved area. You see, now the shaved area is almost 5 centimeters. Then we remove the fat tissue on each side of the shaved area because our stapler will close on this lateral wall. And if we include the fat tissue into the suture, we may have a fistula. And then we put a stitch on the inferior limit and on the superior limit of the shaved area, a very big shaved area, you see. Then my colorectal colleague will push the transanal stapler closed until the inferior limit. Then it will open the transanal stapler. You see the anvil goes above the shaved area. But at that moment, I will do the knot. And by simply doing the knot, the shaved area is pushed inside the lumen. Then I push the thread down, and my colorectal surgeon pushed the stapler up in order to avoid to catch the posterior wall, as you can see in this draft. So you have to avoid to catch the posterior wall. And we remove something which looks like a calzone, you know, the pizza which is closed, because there are staples on the rectum, but also there are staples on the specimen we remove. And by opening this stapled line on the specimen, our calzone becomes a pizza, a disc. We check, of course, the quality of the suture, and we do not perform stoma. We check the vascularization with the ICG. And as you can see, we are very satisfied. Now, we can have two outcomes, two types of outcomes. We may have immediate outcomes, immediate complication, and we may have long-term complication. The long-term complication are also the most important, and they are related to the function of the rectum we leave behind. So the functional outcomes are multifactorial. It depends in outline on the shape of the rectum. So it depends on the technique we do on the rectum, but also depends on the innervation. It means it depends on what are we doing on the parametria, on the inferior hypogastric plexus in order to preserve the nerves of the rectum. And then it depends on additional hidden post-preoperative functional troubles which may become obvious only after removal of endometriosis. And nobody should perform this surgery without being aware about the risk of LARS. LARS is low anterior rectal resection syndrome, and it may be the result of the denervation of the rectum, of the stenosis of the suture, of the dramatical reduction of rectal reservoir if we perform a low rectal resection, with a risk for fecal incontinence, urgency, very frequent stools, or terrible constipation. And this LARS should be the main goal of the surgery. The main goal should be to avoid the LARS, because the LARS is a long-term complication. The patient will have this years and years after your surgery. In order to push ahead the conservative surgery, I carried out the unique randomized trial comparing the conservative to the radical approach, and I published it in 2018 in Human Reproduction. We randomized 60 patients with big rectal nodule in the arm conservative and an arm radical, and we followed them up very closely to see, to understand the rectal function after our surgery. And I was amazed to see that 2 years after the surgery, the rectal function was not very different. And at that moment, I was upset by these results, because in my mind, the conservative surgery should be better than the radical surgery. But I understand that I have a very important confounding factor, which is the denervation of the rectum, because all the patients with big endometriosis nodules have also infiltration of the uterosacral ligaments, of the parametria. So in numerous cases, we sacrifice the nerves. So the rectal shape is important, but it's not the unique factor. What is important to know that now the patients are followed up until 10 years, and I am about to publish the 10-year follow-up article. And this article showed that 10 years after the surgery, the rectal recurrences rate is very, very low, while the patient improvement is constant. It does not impair in time. So 10 years after the procedure, the patients have still a good improvement. And furthermore, when the patients try to get pregnant after the surgery, in 80% of cases, they could do it, and in majority of cases, they were pregnant naturally. It means that the surgery of advanced endometriosis with colorectal involvement works in patients who want to get pregnant after. So it preserves the fertility, improves the fertility, and does not impair the fertility. As regards the immediate complications, you know them. You speak about fistula, we speak about infection, we speak about pelvic abscess. Without any surprise, their frequency increases from shaving to segmental resection. In outline, when you perform a conservative surgery, you can expect less complications than when you perform a radical one. As regards the fistula rate is anyway low, so we have a 3.4% fistula and leakage in 1,000 patients, article published in 2020. So the risk of fistula is low. The surgery of colorectal endometriosis is associated, when it is well done, associated with very low risk of immediate complications. So I used to tell to my patients, you have this big surgery with resection, with everything you wish. You have 9 patients out of 10 will have no complications. So you have to be in this 9 patients out of 10 and not to be the unique one out of 10 who may have complications. But even when we have complications, we will repair them. But if you decide to perform a disc excision of the segmental resection, so a suture on the bowel, you increase the risk of fistula by 5 to 6 fold. So the shaving is a very secure, is a very safe technique. Should we do a stoma in order to prevent a fistula? The answer is no, because we compare different periods of our activity. The first one where we were performing a lot of preventive stoma in women with rectal and vaginal incision. Then a period where we decrease the risk of stoma with the third period where we do not longer do any stoma, preventive stoma. And during the through these 3 periods, the rate of fistula and leakage is exactly the same. So if you perform a stoma, you will not expect to see less fistula. You will have just less peritonitis after fistula, but this we can avoid by a very careful follow-up during the 10 days after the surgery. So stoma finished completely at Ifemendo. So what we can do in this case? So what we are doing is that if we have nodules on the sigmoid colon and upper rectum, let's say over 10 centimeters far from the anal verge, we do rarely shaving because on the mobile bowel the shaving is difficult to do. We do not do too much disc excision. We prefer the segmental resection. Why? Because the rate of the risk of LARS is very, 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 very low. So the functional outcomes are expected to be good anyway. So we preserve them. We privilege the most radical technique on the sigmoid or the rectosigmoid junction. The approach is completely changed when we go down on the mid-rectum, on the low rectum, where we try to do as frequently as we can disc excision, because in our opinion, it is the best compromise between a radical technique and the lack of recurrences. We avoid to do shaving because if we have a recurrence, then it's very difficult to come back. And we avoid to do rectal resection because of the risk of LARS. So we privilege large disc excision, as you saw in my movie. So in conclusion, I think that deep endometriosis, not endometrial, endometriosis surgery is a new surgical specialization, and I believe this. That's why during the last 15 years, I completely stopped to do any other surgery except in endometriosis, because I strongly believe that if you do only endometriosis, you will be very good. It does not mean that I achieved, but I think this is the way to follow. The goals and approaches of the endometriosis surgery are completely different from those of cancer surgery. That's why Michel Canis was telling recently at the AAGL that the surgery of endometriosis, complex endometriosis, should not be done by guys who know the technique. It should be done by surgeons who know the disease. You have to try to be conservative to preserve the function, but also radical enough to preserve, to avoid the recurrences. You have to balance between radical and conservative in order to privilege the function. The function is the most important thing in women 30-year-old. I think that a high volume of activity gives you the tools to do the best surgery in the most complex cases, and you need to master various techniques. It is not longer possible to say shaving in everybody or radical resection, segmental resection in everybody. So thank you very much. You're always very welcome in any center, Ifemendo, in Bordeaux, but also in Abu Dhabi and also in Romania, which are also very amazing centers. Thank you very much.
Thank you, Horace. That was an excellent talk, and you gave us a lot of ideas that should be practical, that one must get into our practice in the evaluation of the patient with endometriosis. And it's not something like you can examine a patient in 10 minutes. As you always say, you need to take your time, understand her problem, get a good history, get a good evaluation, do your ultrasound, look at the MRI yourself, study it, and then discuss with the patient before you get into the surgery that should be done. Your surgery has always been brilliant, and it was wonderful looking at whatever you displayed and taught us, and made it look so simple. It's not simple, I can tell you, after watching hundreds of surgery and being part of the teams. So there's a question from the groups asking, do we need to give any hormonal suppression after bowel nodule resection to prevent recurrence in patients who are not interested in planning to get pregnant?
Yeah, this is an excellent question. Of course, we have a disease. We do not know where it comes from. We do not know where the lesions come from. So we do not know how they can recur. We know that the risk of recurrences is real. The risk of recurrences is variable depending on the localization. So in rectal nodules, we saw a patient 10 years after the surgery has 5% risk to have a new nodule. The risk is much, much higher in ovaries. So if you perform a cystectomy, if you do not give a pill, 2 years after the surgery, 30% of patients will have another endometrioma. That's why I routinely propose to patients who have excision of endometriosis, rectum, ovary, of any other, to take a pill if they are free of side effects, and if they agree, and when they ask me how long time until the menopause, because the risk of recurrence is until the menopause. I think it's not logical to give her 6 months of pill. It does not mean anything. If the patient has 25 years, 6 months of treatment does not represent anything. So I propose them to take a pill. What's happened in theory, everything works very well with the pill, with amenorrhea, when the patient has a 30 up to 40-year-old. After 40 years, when you have some adenomyosis, the continuous pill intake is associated with frequent bleeding. So the honeymoon with the pill stops. So in this case, we can discuss to do a hysterectomy in order to stop all this bleeding, and then we continue the pill. Yes, so the answer, simple answer is yes, I routinely propose a pill after the surgery in patients who wish to take it. Now I see in France, less and less patients agree to take the pill. So in France, there is a current of opinion against the pill, against the hormones, which like ecological, free nature. And I do not insist, I propose, but it's not a condition to perform the surgery.
Thank you, Horace. There's one last question from someone in the group who wants to know what is the incidence of malignancy in DIE cases in your group?
Wow, it's very, very, very low. I know that once we had a patient with colorectal endometriosis, very big nodule, and close, another lesion much more unusual, and there was a cancer, a colorectal cancer, so it was a concomitant lesion. And I had 4 patients where I removed the rectum and then I removed the appendix because I thought it is not normal, and we found malignancies into the appendix, and the patients were cured. And I have a last case, I have to publish it. A patient managed 6 years ago a big, huge nodule of the rectum, lower rectum, parametrium, sacral plexus, and sciatic nerve. The surgery took, I think, 8 hours, which is huge for me. And in this patient, on contact with the sciatic nerve, there was a clear cell carcinoma. So this patient has been postponed for years because the surgery is too risky, because the surgery is too complicated. And fortunately, I carried out the surgery, I cured her cancer. So of course, after this, she had the second surgery by open surgery to remove all the ganglions, but nowhere was found another tumor cell, except it on contact with the sciatic, and she's still alive.
Oh, that's good.
So this is an excellent case report. I need just to have the time to, because now we have 5 years follow-up. So, but here the surgery of endometriosis cured the patient, so saved her life.
Yeah, perfect.
Yeah.
Okay, so are there any other questions? Otherwise, we can ask Mala to take over.
One more question, sir. Infertility conscious patients with asymptomatic bowel nodule, is it advisable to go ahead with colorectal surgery, or should you do a second sitting when symptoms develop?
So, can you repeat just once more?
In women who wants to go in for a fertility treatment, is it okay to do a colorectal surgery, or should you do it as a second sitting when symptoms develop? Asymptomatic, and she is not symptomatic.
Well, this is another big chapter of the endometriosis. How we manage the patients with pregnancy wish and severe bowel endometriosis. Now, the general opinion is that if the patient is not symptomatic, you can refer her for IVF. But in my opinion, performing the surgery increases her probability to natural conception. While the IVF, if it does not work, the patient will come back to the surgery with maybe larger lesions. So I think that this is the specific type of patients which should be discussed in multidisciplinary teams. But always I said, if you discuss the case in the MDT, take care to have a good surgeon, because if the surgery is complicated and there is no good surgeon in the team, everybody sees it's better to refer her to IVF. While for me, the surgery, you saw in my Syrian endometriosis trial, 80% of patients were pregnant, 75% of patients who were infertile before the surgery had been pregnant after the surgery, and more of them by natural conception. So for me, the surgery is a very good treatment if the fallopian tubes are in good shape, if the sperm is acceptable, and if the patient have ovulation. So if you do not have any over infertility factor associated to the endometriosis, frequently I propose them surgery, also because asymptomatic patients with very big lesions are very rare.
Yeah. So your message is, even if she's asymptomatic, if she has a bowel nodule, better to go for surgery in infertile.
But if she's completely asymptomatic, if she has no bowel symptoms, no. But also think about referring this patient in IVF without giving her the possibility to try a natural pregnancy. I think it is as excessive as to say remove the nodule even though she's asymptomatic.
Yeah.
So it's a big debate. That's why right now we have two randomized trials. We have one randomized trial who try to see patients with bowel endometriosis with pregnancy wish. We randomize between IVF and surgery. Because if you refer a patient with bowel endometriosis to the IVF, we know that the rate of pregnancy is 65%. There are two studies published by French teams who show that you can expect 60%, not 80, not 90%. So the patient should know.
So what is the commonest bowel symptoms most of these patients present with?
Depending on the localization of the nodule and the size of the nodule, most of patients have bloating, they have constipation outside the periods, and diarrhea during periods. Why diarrhea? Because the inflammation during the periods is associated to excessive secretion of the rectal mucus, and they have diarrhea with mucus. So a patient who said, I'm very constipated during outside the periods, and during the periods I have 4 to 5 stools with a lot of mucus, and I have bloating, everybody asks me or congratulate me because I'm pregnant. You can think about bowel endometriosis. And if you don't see anything on the MRI, on the bowel, on the rectosigmoid, think about the ileum. So make sure that she does not have an ileal lesion, which may lead her to the occlusion.
Okay. So how do you decide, sir, about shaving disc and resection. On what criteria?
I put together several factors. First is the age. If the patient is older, I do, in majority of cases, I do shaving because the risk of progression is very low. If the patient is not very symptomatic, I am more conservative. If the patient is very young, I'm more radical.
Young.
So if the patient has 20, if the patient has a big nodule, 25-year-old, and she has 25 years until the menopause, I cannot do a shaving. She will recur. So I consider that she has a very aggressive disease, and I have to treat as aggressive disease. So I'm more likely to do a big disc excision or a radical resection. So these are the factors. So age and
size of the nodule,
the depth of the nodule, size of the nodule, number of the nodules. And just 4 days ago, on Tuesday, I carried out a surgery in life to Israel. And of course, the surgery is 3 hours. But if you can go on my Facebook or YouTube and look at the first 5 minutes, because on the 5 minutes, you will understand that the difficulties and the danger of this situation, endometriosis. The patient had a big nodule on the rectum, and she had on the sigmoid, but very, very far, a subocclusive nodule. So you'll see, just think, if you were in the surgery of this patient, what was the probability that you miss the subocclusive nodule? And in this case, we had 1 subocclusive nodule on the sigmoid, 1 big nodule on the rectum, and 15 centimeters of rectosigmoid healthy between the 2 lesions. And we decided to do a rectal resection and the sigmoid resection. So we did a double resection in order to spare the 10 centimeters between the 2 resections. So it is a conservative radical surgery.
Okay, so will the patients have normal bowel function after the surgery, and how long does it take to resume, or will she have any kind of hurrying or any kind of bowel dysfunction after the surgery?
So majority of patients have a very good bowel function after the surgery. Of course, we have from while to while we have LARS. If you have a LARS, you have to understand where the LARS come from, and then there is a specific management of the LARS. I don't want to detail now. But in this case, you have to follow them up. But a large majority of patients have normal bowel function and very fast, 1 or 2 weeks after the surgery.
Okay, so lifelong, I think they have to be under follow-up now, sir, or what do you think? Like how long do you generally follow up these patients?
After the surgery, the colorectal surgeon see them 1 month later, and me, I see them back 3 months later. And after that, if they feel very well, I do not longer see them. We just send them follow-up questionnaires. And if she has a LARS, of course, we see them every 3 months to try to find solutions to improve the bowel movements.
Okay, so any kind of medical medicines you give them after the surgery to prevent any kind of a recurrence?
Yeah, we give them a pill. I ask them which is the pill you're used to take without side effects, and I choose this pill.
So thank you so much, sir. Excellent presentation. So I think it was a great session. All the 3 speakers were really wonderful. The disease is complex. The surgery is also complex, but you all made the surgery look very simplified. So that is the beauty of a skilled surgeon. And as you rightly mentioned, it is not the surgeon who knows the technique. It's a surgeon who understands the disease is who has to operate. So very beautifully said, and all very clear-cut take-home messages. Thank you so much, Professor, for your valuable time and also for sharing your knowledge so beautifully in a very eloquent and a very simplified manner. I would also like to thank Dr. Benjamin also. I think he has left for his congress. and Dr. Abhishek also for sharing his knowledge. And also, it is really wonderful to know that we have a very skilled surgeon even in India. I think with this, sir, Prashant sir, would like to add something?
Well, you said summarized everything. It's always nice to watch and hear Horace and Benjamin. Of course, I've been hearing Abhishek every day.
Yeah. So can I request our Secretary of IAG, Dr. Sujal Rishi, to give away the vote of thanks, please? Yeah.
So
yeah.
I just want to congratulate Dr. Malaraj and both the coordinators for wonderfully coordinating this whole session. It was really great discussions and lot of insight into the DIE. So thank you very much. Thank you, sir, Prashant Mangeshekar sir, and Dr. Abhishek also for making this happen and requesting and coordinating with Dr. Horace and Benjamin sir. So thank you very much, and we hope we will have lot of more interaction on this subject in coming years. Thank you, sir.
Thank you so much to all our faculty and our chairpersons and also our coordinator. And from the bottom of the heart, I would like to thank IAGE for giving me this opportunity to conduct the Scope and Troca series every month. So I'll also take this opportunity to thank Shield Pharma for supporting us every other month and Sahiti for doing an excellent job and for the seamless transmissions. So see you all in the next month with the next Scope and Troca series. Thank you, everybody, and see you all. Bye-bye.
Thank you, ma'am.
Thank you, madam. Thank you, everyone.
Great. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Thank you, sir.